Welcome everybody, Jemsek Specialty Clinic live on Facebook. My name is Rachel, for those of you who don't know me, and Dr. Jemsek's with me as well. Just an update on the clinic. We are still seeing patients, mostly phone consultations, but we are still doing some office visits with precautions, wearing masks, wiping everything down. So just so you're aware, we're still operating as normal as we possibly can. The format for today, we're going to be answering questions like the live that we had about a month ago with Carrie. I'm going to go through some questions from the Facebook, questions that you guys posted over the last few days, as well as questions from Instagram, as well as questions that we get during this live. If we don't get to all of your questions, we will address them at future live events. So let's get started. I'll turn it over to Dr. Jemsek first.
Hey, good afternoon. And thank you, Rachel, for joining me today. She's an outstanding provider, by the way, as all of my associates are. That should be no surprise to anyone. So I want to start off by giving some good news for the future. At some point in the fairly near future, we're going to initiate that GLA study that was announced a few weeks ago and was actually supposed to start in March before this wonderful COVID event occurred. Our new patients, that is, list and enrollment is down, as one would expect, because we're a destination practice and people are afraid to travel. So we get that. And I think most of you know we've seen patients from all 50 states and several hundred international patients. Well, that's over with for now, of course. But in any event, we feel like we have enough new patients coming in, and I've had discussions with Global Lyme Alliance, GLA, one of the top, if not the top, charitable organization supporting Lyme borreliosis. We had discussions with them. They are supporting the study, and it's all patient funded. And we are working with 3 universities doing very specific and very interesting diagnostics for biomarkers, immunologic markers, and so forth. So it's the first time ever that anyone's done this, and they're using our treatment, our clinic, and they really like the way we approach patient care, and they know we have great outcomes, as many people have told them. So we're finally going to start. I don't know when, but it may be soon. So I wanted to let you know that, and we're very excited about that. Now, you know I love my patients, and I get a lot of gifts, and some of them are liquid, and some of them are just funny. And so I just want to show everybody this gift I got from my wonderful patient. Everybody see the markers here? Oh my God. We got our lavender, our blue, green, orange, yellow, and pink, of course. And I'm all set. And of course, in every room we have our little set of markers as we, the only problem, so I know how to do the marking, you know, so when we put a drug down and I mark it, I'm consistent, but Rachel, no offense, but Rachel, Kim, and all the others, they just don't know how to do it. And I can't teach them. So if you come to me, you have the best highlighted schedule ever. So I'm going to turn it back to Rachel.
I would just like to point out that we do know how to write the protocols. We just have different opinions on which colors to use. And I will say that my handwriting is better. But let's get started with some questions. I'm going to start with some of the Facebook questions that you guys posted. Thank you so much for sending those in. The first one, what's the story with Lyme and other infections and head pressure, especially at the back of the head? Also, neck issues. What do we have to check for, and how can we manage it better? Dr. Jemsek?
So headaches are part and parcel of this illness. The infections love the lower brain, the brainstem, and the cervical plexus. So we'll see various types of pain: neuropathic pain, myofascial pain. And I would put it in 3 categories at this point. One is, and the pressure that you're talking about is a different type of pain. So when we talk about global pressure, a band is around the neck, around the forehead, or it's squeezing in, squeezing out. very uncomfortable. That is inflammation of the dura mater surrounding the brain. The brain has no sensory fibers. So the dura mater gets firing off with or without treatment, and the head feels like it's going to pop, or else somebody's got a vice on it. So we call that an inflammatory headache. That's number one. Number two, and probably more common, is what we call a cervical plexitis or C2V1 headache. We coined that term. Now, C2, if you reach behind your head and feel the occiput, C2 is the first cervical fiber that has sensory properties, and it innervates this part of the head. C3 goes down one level and innervates this, and C4 innervates the traps and back here. So it's very common for our patients, and you know how carefully we examine everyone. So when we touch and tap, we're looking for angry nerves, and it's very common to have a set of angry nerves, especially in the neck, and it's very uncomfortable, and it's very consistent. The third headache is one of what we call cervical instability, and this disease not only devastates neural pathways, both motor, sensory, etc., anything really, but it also attacks tendons and ligaments, and in people, especially with Ehlers-Danlos, but not necessarily Ehlers-Danlos, will have so much inflammation in the ligaments and tendons supporting the neck that they get into a neural looping pathway, which then recruits, nerves in the head. And I should go back to C2V1, because you say, okay, well, it innervates this. How come I get a headache in the face? It's recruiting the trigeminal nerve, because it's exciting the trigeminal nerve is what's happening. So a headache will start here, and I'm talking about the second one. Headache will start here, and then often recruit the fifth nerve. And so we got a patient with a hemifacial headache, neck ache, and so forth. And sometimes you have combinations of all two or three. That's a very good question. It's so common. We use neurotropic medication, but we really like to use a cream at the exit point of some of these neural pathways. We think that works very well.
All right. The next question is patient who was seeing improvement but still has neck pain, which is unrelenting, and there is a lump at the back of the neck next to the cervical spine. Do you think this will eventually go away, and what should I do about this? Touching on Dr. Jemsek's comment, I think a lot of the neck pain that's unrelenting, some of that, needs treatment, and then also, time to allow those nerves to calm down to resolve some of that pain. In regards to anything structural, like the lump that you're talking about, we urge everyone to get those evaluated to ensure there's nothing structurally concerning. The next question is in regards to mast cell activation, which was a popular question with you guys. So wondering about mast cell activation, is it linked with a cytokine storm? And can you touch on that a little bit further, Dr. Jemsek?
Oh, thank you. So this is the darling of the last several months, is mast cell activation. And one of the problems is that when it becomes popularized and recognized, it becomes the problem. Well, it's not the problem, it's the manifestation of the problem, which is inflammation of the body. Mast cell activation promotes cytokine release in the form of histamine. Histamine is not our enemy, but in excess and with very sensitized tissues, especially neural structures, it becomes excitatory and in most cases painful. And most of you may know that itching is a form of pain because it's really down the same neural pathway. So we can see there's a bunch of cytokines released when things get inflamed from the gut to the throat. But we can see histamine. And so we say, this is a histamine problem for sure. Well, it is, but there's also a cytokine problem with IL-6, IL-2, TNF, interleukin, and so forth, but we can't see them. So we see the histamine program, and that's fine. And it's not that hard to diagnose clinically, in my view. Histamine is produced 80% in the gut and 20% in the brain and elsewhere. There are various things that can stir up histamine in the gut. There are certain drugs that actually break down histidine, which is the amino acid precursor of histamine. And so we had to be careful in looking at the drug list. Once we've attacked H1, H2 receptors, And we've done mast cell inhibitors with Singular and the rest, or gastrochrome, and maybe doxepin or ketotifen. We get a cocktail going. We start with 2 or 3, H1H2, and probably also DAO, diamine oxidase, which is a naturally occurring enzyme in the gut, breaking down histamine. It just gets overwhelmed. So and it's good, because if we can reduce the histamine, we've taken the inflammatory quotient down a notch, which is a good thing. But we also employ a lot of other measures to reduce inflammation in general, and depending on what the situation is. One other thing I didn't mention is quercetin, which has become very well known these days, but happens to be a very nice antioxidant and also a very good antihistamine.
Just piggybacking on that real quick from one of the live questions that just came in. One patient was asking, or person was asking, do we need to avoid all foods that are high in histamine?
Just don't eat them 3 times a day.
Don't overdo it.
You can't avoid them all. There's so many things that have histamine. And I try to be reasonable with everything. And if you know that strawberries or spinach or something that you love has histamine, eat it once in a while, but just don't gorge on it.
The next question is, what might cause a patient to gain weight while on treatment, absent of any change in diet or exercise?
This is an excellent question. Thank you very much. We see this every day, and I'm going to do a little handwork here. So this is you're in neutral right here. Let's say this is 12 o'clock. And when you get inflamed, we're all trying to keep it in neutral. And if we're well, we can do it easily, because every time we talk or eat or move, we're creating radicals, and they're neutralized by glutathione and other antioxidants in our body. But when you have a chronic inflammatory storm, that's overwhelming, our body's endogenous antioxidants. So what happens is, despite exercise, despite more sleep, despite gluten-free, patients often gradually go this way. And once they get to a certain point and become quite dysfunctional, they get into what I call a wedge, an inflammatory wedge, which then calls on survival mechanism, because the body thinks it's dying. And so what happens is you become insulin resistant, leptin resistant, vitamin D resistant. The fat cells resist lipolysis. They don't want to break down. You eat 1,500 calories a day, you still gain weight. And believe me, I've been yelled at many, many times about, why am I gaining weight? I've got to get a new wardrobe, and I don't eat a thing. And, I explain, and I say, listen, don't beat yourself up. Now, one thing I did that wasn't very good early, a few years ago, when I was explaining this, I called it the fat wedge. And then I got really yelled at. So, so I don't do that anymore. I just call it this little inflammatory wedge. Now, if you go beyond the wedge, you're going to get catabolic. That's where you look like you're dying with AIDS or cancer, because there's so much destruction. You start breaking down not only the fat, but you break down muscle. We break down muscle. So anyway, that's the answer. Don't beat yourself up. We got to get you out of inflammation. We got to get you better, and then the meter will come back to neutral, the isotonic.
Yeah, he got in a lot of trouble for that. This next question actually piggybacks off of that question. Somebody wrote in asking, why is a strict diet so important for some and not as much for others? And I think a lot of that is, part of that kind of inflammatory burden that Dr. Jemsek was talking about. In addition to the fact that we know a lot of our patients have leaky gut, which, allows for them to absorb nutrients appropriately or inappropriately. Your genetics play a role, your gluten intolerances versus true celiac play a role. And so some patients will see that making those dietary changes really makes a big difference in their weight loss, whereas others don't. We still encourage it because we think reducing as many variables as possible, including microscopic inflammation, is really helpful when trying to treat a Lyme patient. So that's why we still encourage it. The next question is for Dr. Jemsek, and it's a patient reporting very low IgG subclasses and what we can do about low IgG.
This is a epiphenomenon in the immune set that has occurred because of immune depletion, immune exhaustion, and mediated through the lymphocytes, not communicating very well, the T cells not communicating very well with the B cells, which don't communicate very well with the plasma cells, which make the antibodies. I've seen it so often, other physicians will reflexively say, oh, all you need to do is take some IVIG or sub-Q IG, and we'll get those antibodies up. Problem is, they only last 15 days. You have to repeat it, and they're expensive and a little bit risky because it's pooled plasma. And this hasn't been reported in the literature, which is criminal, quite honestly. This is one of the things the GALA study will look at and determine. And over the long term, we'll see if those numbers come up once the immune system is reconstituted. This is different from variable immune deficiency, which I've treated as an infectious disease physician. And this is a situation in which our patients have recurrent sinusitis or pneumonia with encapsulated bacteria such as pneumococcus and Haemophilus. And this does require hospitalization and periodic IVIG infusion to keep people out of the hospital. In our situation, functionally, with our patients, which is where this is so widespread, fortunately, they don't, from a functional point of view, get into trouble with opportunistic bacterial infections.
Just a quick question that somebody had just typed in, which is easy for me to answer real quickly. They were asking if we were treating international patients, and more specifically international pediatric patients, and we are. We have a pediatric nurse practitioner, Candace. She's wonderful, and she is taking patients at this time, just to answer that quickly. The next question is in regards to antiviral medication. Are antiviral medications useful for patients with high CMV and EBV titers? Dr. Jemsek?
You know, as an infectious disease person who did HIV work in the 80s and dealt with, and I also did transplant medicine for a number of years with the heart transplant group at Charlotte. EBV was a concern there because of the profound immunosuppression. And CMV I've treated treated CMV retinitis, I've treated disseminated CMV. These organisms are simply not sensitive to Valtrex, valcyclovir, famciclovir, acyclovir. You have to go to the next level. And the question is this an immunologic epiphenomenon, or is it a real infection? And I tend to believe that it's not a real infection because I've gotten so many people better without using antivirals. On the other hand, if someone says, you know, I feel better on Valtrex, my threshold for saying, okay, take Valtrex because its morbidity is so low and it's so well tolerated and virtually no drug interactions. So I'm okay with that, but I don't use it routinely because I think these elevated titers for EBV, CMV, and other viruses are smokescreens and just epiphenomenon.
Okay, the next question is asking about the likelihood and symptoms of Lyme carditis in children who are in treatment for Lyme and co-infections. This is something that we do see in the Lyme population, Lyme carditis, both with pediatrics and with our adult population. What we typically see is that unless a pediatric patient has come to us initially with previously having had Lyme carditis, the likelihood of starting treatment causing or provoking Lyme carditis is quite low or rare. Dr. Jemsek has some thoughts or pearls on cardiac symptoms in general, however.
So cardiac abnormalities scare the heck out of everyone. And if there's any atypical chest pain or typical, but by far in our patient population, the most common presenting cardiac symptom is a resting tachycardia. So folks will come in with a resting heart rate of 90 to 100. And the typical scenario is that they've been to half a dozen doctors, had a couple echoes, maybe a treadmill, 15 thyroid tests, and so forth and so on. They may or may not have POTS or postural orthostatic tachycardia syndrome, or they may not have NMH, neurally mediated hypotension, along with this. It's not necessary. again, by far. And I think the etiology of this is not disease intrinsic to the sinus node. I think it is the vagus that's been affected. So the vagus puts a brake on the heart. And the vagus definitely gets hammered by these infections. And so I'm convinced that's the etiology. There are other cardiac issues a little more serious. I do believe there's focal myocarditis without question. Why wouldn't there be? And then finally, I don't want to scare people, but we've had 15 or 20 patients at no risk for cardiac disease who have either died or had a serious anterior MI through obstruction, a single high-grade obstruction of the LAD, the left anterior descending artery. I think there's something going on hemodynamically and from an endovascular point of view with this illness. And there's no question. So it begs the issue, should people have cardiac CT angiography? And I'm for that. So this disease can do these things, but not commonly, but it does happen.
Next question is, can you explain the many ways that the spirochete can get into your body? So this is a pretty straightforward question, and multiple of you asked this on both Instagram and Facebook. We think that insects are one way that we can get the spirochete into our bloodstream, and we know that it can go from the bloodstream into many other areas of the body. We think that ticks are the most well understood and obvious answer to that, but fleas and mosquitoes, so both insects and arachnids, are possible. We also think that Lyme can be sexually transferred, and we also think that it can be transferred congenitally or from mom to baby in the womb. The next question, what protocol do you follow for newly diagnosed patients following a bullseye rash? Typically, if a patient gets a tick bite or doesn't even see the tick but sees a bullseye or EM rash, the recommendations that we follow are to do 4 weeks of doxycycline or a combination of broad spectrum antibiotics such as amoxicillin and minocycline. If the patient responds to this well, has no symptomology after or during, they're good to go. No follow-up really needed. If they start to have neurologic symptoms based on a response to these antibiotics, we recommend they come and see us for follow-up because they'll likely need further treatment. Okay. If a person tests positive for Lyme but shows no symptoms for years, is it likely that they will succumb or possibly spread this to a partner sexually? Dr. Jemsek?
Yeah, I mean, I don't think it's that controversial to say that this is sexually transmitted if you look at the organism. And also we look at families of 3 to 7 people, many of whom are infected. So we think some's congenital, some it's transmitted through genital secretions. I think an asymptomatic person will shed genital secretions. I think a highly symptomatic person will shed more. And there's really no good answer. We do have little tricks when we treat somebody about maybe their partner taking the maintenance program after a year or two of therapy along with them simultaneously. But I'm not sure how much good that does. It's at least something. So I tell most folks, hey, listen, this is a guilt-free STD, and not your fault. And it's just the way the world is. Remember, with this illness, it's all about the immune system staying ahead of the infection load and the synergy of the infection load, and that's determined by many things, including whether you're infected with all the usual pathogens.
And then the next question is, on average, how long does it take to treat a patient with chronic Lyme disease after initial diagnosis? Here at Jemsek Specialty Clinic, we typically feel that treatment can be completed in between 15 to 18 months of more rigorous treatment, whether you're on IV or oral antibiotics. And that's typically followed by a 2-year period of time on what we call maintenance therapy, which is minimal antibiotics but focused on healing during that time. Suffice to say, some patients have more persistent or stubborn co-infections, so sometimes that will mean that their treatment may take a little bit longer than the 15 to 18 months. Counteracting that, our pediatric population many times actually has a far shorter treatment time. It's convenient to have a young and spry immune system. So the next question is, are oral antibiotics or IV antibiotics more effective? So this is a common question that we get from our new patients that come to see us. We think that both forms of treatment are very effective. Our oral antibiotics we use in combination and in a pulsed fashion, which we do think can penetrate or cross the blood-brain barrier. So it's important to mention that first. IV antibiotics are, of course, very effective in regards to time frame because they bypass the gut and are thought to get across the blood-brain barrier a little bit more efficiently. When we're trying to determine whether a patient should do IV therapy versus oral therapy, a few things, come to mind. Patients that have, advanced issues with cognition, presence of Lyme in a lumbar puncture or spinal cord, which is objective evidence that we're given, gastrointestinal issues, which would likely worsen with oral antibiotics, and also an effect on optic nerve or vision. We think that those patients might be more IV candidates and would benefit from IV therapy followed by likely oral therapy. The next question is, in your opinion, what are the most effective drugs against Babesia? Dr. Jemsek.
So that's a very good question. It's a tough question, and we've learned the hard way over the years that we need combination therapy, and we try to do it in a smart way. We're constantly looking for other medications which could augment or have an additive effect on this very tough organism. On the one hand, we want to treat the Babesia early in the treatment phase. We want to use effective biofilm disbursement because years ago I discovered that Babesia in fact lives in the biofilm. So this is a huge reason why people don't get better, because you're just kind of skimming the surface with your drugs. For other things that you should know, your provider should know, is please don't use monotherapy or don't use Zithromax and Mepron. All you're going to do with the Mepron is develop resistance. There are two modes of resistance for Mepron, and once you've created that, you've wasted the atovaquone group. So the most effective drugs in combination, what we typically do is something from the Artemisia group. Artemisinin is our preference. If we could get artesunate, that would be great because it's all about how much dihydroartemisinin you can generate, because that's the active drug form, and you get more from artemisinin artesunate than you do from Artemisia. But some people can't tolerate artemisinin. The other group is the atovaquone group, Mepron and Malarum. Mepron is a classic butt of jokes, and some people take it fine, other people just so disgusting. But it does act on the respiratory chain, and it is effective. Shouldn't be taken with CoQ10 for that reason. By the way, artemisinin groups work on the iron metabolism within the organism. Another product is annula, which is a naturally occurring substance. Annula acts functionally a lot like Artemisia. And then there's cryptolepis, which is an amazing molecule, and people hate it. They find it disgusting. It tastes like dirt. So we're encapsulating it and using it, but it's an amazing drug. It synergizes very well with some of the others, especially artemisinin, and has antiprotozoal activity, and is Dr. Zhang, who's we're becoming fairly well acquainted, the microbiologist in Hopkins, did a study on botanicals and found that cryptolepis, in addition to its coverage for Babesia, was the best of the bunch for the resting and active form of Borrelia. Then finally, we're starting to work with methylene blue, which has been around since the late 19th century, and some very good papers showing its efficacy against Bartonella. It's also a very good malaria drug, but it's not as good for Babesia unless you pair it with artemisinin. So that's another member of our group. And we'll use biofilm overlay. We'll usually have a backup stable beta-lactam just to keep the wild type, honest. So something like Omnicef, Augmentin, amoxicillin, ceftonir, or cefuroxime. And then I like to pick a drug from the malaria history, where they've been used, and that would be things like clindamycin, sulfa, doxycycline. So we have quite a combination going 3 days a week the first week, and then the second week we go all the way through and we do a kill week. Sometimes we'll add coartem on the third week to give it an extra kick, and we'll see how the patient responds to that. We are probably going to change the way we treat babesia in the future because, as many of you know, I feel it's the #1 cause of stalling out or relapsing with Lyme borreliosis complex. And then I think the huge reason for that is the immune system is just MIA. It's not helping, and we need our immune system to help against this really tough bug. So I'm seriously considering we'll be starting treatment once patients get into maintenance. So they're in their second year, for example, they're in month 13 or 14. Let's have 3 or 4 good months of maintenance, and then let's do another babesia round, because I am sick and tired of the relapses. And it's only 10 or 15% is too many. Thank you.
The next question is, do you think that it's possible to cure Lyme disease completely? This is one that we get a lot as a question. We are hesitant to use the word cure at JSC. There is not a test of cure out on the market, and so it's concerning to use that word. We do think that we get patients into a deep remission, and so we typically talk about it in that capacity. The next question is asking about a connection between morgellons and Lyme disease.
Well, yes, there's an obvious connection, and I've seen quite a number of patients. It's a horrible thing to have to deal with because it's very distressing, it's very visible, and you're extruding fibers and granules from your skin, from your mucous membranes, and so forth, and it's tough. So I think, first of all, you get after the Lyme component, and I do my usual program, but then I add things like albendazole, and then on the off weeks I'll do things like ivermectin. And I think a clinical point to be made is that if you can just imagine that if you're having these organisms, whatever they are, migrating from the gut, you have to understand they're not creating that much inflammation, so they're antigenically rather inert. Because I can't imagine the torture that it would cause if you had a big reaction with these thousands of migrating matter, whether it's fiber or granules. Now, recently I've been intrigued by, and it's about a year ago, 2 years ago, about the group Archaea, which is the thermophilic group. And we have eukaryocytes and prokaryocytes. So we have all the bacteria, and we have all the animals and metazoa and protozoa with the nuclei. But in the middle is Archaea, and there's some evidence that Archaea may somehow get in our body and hybridize or mutate with the spirochete, because we know the spirochete, or these threads, have some spirochetal antigen. It's mostly keratin, but it's been shown that there's some spirochetal antigen. So the gut's a big place with trillions of organisms, so there's some monkey business going on. So we're treating with flagyl, which actually is good for Archaea, and we're having success. So we might do a week of flagyl on the off week, and we might do a week of albendazole or Alinea or ivermectin. And we're having pretty good success, I must say. But very little is written about it. It's still trivialized, it's still ignored, it's still ridiculed. And it's very sad because it's a very disruptive and disturbing condition.
Why do you only focus on Lyme co-infections without taking mold and parasites into account? Dr. Jemsek.
Well, we don't. Well, we take mold into account, although I must say I didn't really pay that much attention until 3 or 4 years ago. But parasites always. And we look at the products that we're using, and we feel like we have some pretty good antiparasitic programs going on. We use a lot of daraprim or pyrimethamine, routinely actually. the cryptolepis, and even the annula. And then in the off weeks, it's very common for us just to pulse with ivermectin or one of the other antiparasitics to see what the reaction is. If there is a reaction, now it's done separately, so if there is a reaction, we keep doing it. And then when it stops, we try another product. We're just challenging the gut. So we know that parasitosis is a big deal. Here's the thing, though. You could take a bucket of poop to Tulane, you know, the best parasitology lab in the world, and that poop would be looked at and they wouldn't find anything. But we know stuff is coming out, right? So we know granules and fibers and reactivity is happening. So we know what's in there. The gut is just a mess with this disease, and all kinds of things going on with these hundreds of trillions of organisms. So we do challenge, we do it periodically. And as far as mold, we see it as an accelerant or a decelerant, depending on your view. Somebody live in a moldy house, we can't get them well, but mold is not the driver of this disease. It is a cofactor, and I'm sorry for the mold believers in the world, mold is gold. It's an accelerant, and I respect it, and it's one of our confounding, it's on our confounding list for sure. So if somebody comes in from Great Plains and has ochratoxin or aflatoxin, our treatment is employed, but it's very gentle because we don't want to disequilibrate what's going on in the gut. You have to realize that things are in a sort of a truce or some relatively stable status, and you start pulling out things and creating all sorts of inflammation. Not only does the patient get sick, but we can't treat them because there's so much chaos. So we're very, very mild and gentle. In looking at the situation, no one knows. There's no data to say for sure which of the binders, whether it's bentonite clay or cholestyramine or citrus pectin or what have you. Nobody knows which is best for what, which mycotoxin. So there's a lot of voodoo going on with that. But our thing is go low and slow and be gentle. And we like to do it usually late in our therapy. And we've had good success that way.
And just a reminder, you guys are sending in fantastic questions during the live. I'm writing them down. I'm going to try to address a few of them in between the ones that were sent in already, but we will get to all of them just potentially at a future live. But a lot of them are actually really, really good questions. The next question is Bartonella the cause of neuropathy or is Lyme? So we think that actually both of them are the cause of neuropathy. We know that Bartonella can cause encephalopathy as well as tendinopathy issues. We know that Lyme, which then can lead to neuropathy issues. Lyme is notorious for demyelinating nerves, which understandably causes neuropathy. So we think both of them can contribute. Lyme is probably, again, the steering factor there. Next question would be brain fog that will not go away. Any suggestions?
Well, that's a multifactorial. It all depends where you are in treatment and what other comorbidities you may have. And so that's a hard one. I don't think I can answer completely. There's no way. But I can give you a couple of hints that I think are safe. And the two best studied supplements for neuroprotection, or two or three, are curcumin, which binds quinolinic acid, which is a waste product of the brain, resveratrol, which is very, very good, and thousands of articles in PubMed. It's a phytoestrogen, so I'm a little careful with women who have any kind of estrogen-sensitive history or family history. And our friend quercetin, as well as omega-3. Now, if you're still foggy, we got to know that you're sleeping and that you're rinsing your brain at night. So you need the deep sleep, which is phase 4 in the early part of the evening. That's the first thing I'm going to ask you. And we may do a sleep study. You may do something with one of the devices that can watch your sleep at night and then bring it back to me. We need stage 4 sleep, and it typically goes early. It should be 90 minutes or more. And then the rest of the evening shouldn't be full of awakening and restlessness and all that sort of thing. And then I'm going to ask basic questions. Are you being good with your diet? Are you trying to detox at all? And then finally, one of our confounders is, if you've been on some of the neurotropics or psychotropics for a good while and your brain's actually gotten better, you've had a lot of treatment, it's not uncommon for folks to get a paradoxical effect at that point. So we say, okay, we got to do this. We got to drop the gabapentin slowly. And if that doesn't work, then we'll go back and then we'll drop the oxcarbazepine. If that doesn't work, and it's not uncommon for us to find something and say, oh, I woke up, I feel so much better. But it's a complex question. There's many, you just need to know where you are in therapy. And whether you're doing the right thing, whether you're sleeping, whether you're eating correctly, whether you're detoxing, et cetera, et cetera, et cetera. And, we get this all the time, but this is kind of a cold question on live stream here. So that's the best I can answer right now. If I were sitting down across from you, you'd probably get to 2 or 3 conclusions within 10 minutes.
In regards to COVID-19, when the lockdown restrictions start to ease and people begin to interact more freely, will we as Lyme patients have to remain extra vigilant and avoid interactions as much as possible, or can we relax at the same pace as healthy people?
Another easy question. So it's been on the news 24/7 for 2 months, and you can see the controversies flying around. I'm annoyed that we're not targeting those at risk initially. I also know that there are immunologic tests that would help us define who the atypical folks, the young folks who got sick and died. I'm also annoyed that there's so much pushback against hydroxychloroquine. I'm also annoyed that the incidence of psychiatric and self-medicating issues have gone up dramatically with the isolation. And I'm also annoyed there are 30 million people unemployed. I'm also annoyed the politicians have tried to make hay of this, don't waste a good crisis. Really annoys me. And, St. Tony is really enjoying his time in the limelight here. And we need to get other opinions about this. Never shake hands again and that kind of nonsense. He may be right. This may be a persistent virus, may have another wave in the fall or summer. I don't doubt that. Now the question is this going to be part of our flora? Is this going to become a commensal in our body which will reactivate from time to time? Other questions, are the antibodies we make protective? Do we get natural immunity or not? And if so, how long? And then we got this boondoggle with the vaccine coming, not having any clinical trials, which is ridiculous. You know what I say? When I see the isolation, if you think you're in a safe environment, mask to mask or not mask to mask, hugs for health. Hugs for health, hug hard, hug a lot. Those endorphins come out, the parasympathetic system loves it, and you just feel better, and you need that. So we don't look at the science as we should. It's very low incidence of infection, and unfortunately we've lost tens of thousands of people, mostly from nursing homes, quite honestly. And I believe there are some immunologic reasons for that. I'll be speaking about this in London next week, about some of our theories about which are well published. Why do aged people have more susceptibility? And there's some immunologic changes going on, which we'll try to explain. Also, clearly some histocompatibility issues. That's genetically driven. The people that have trouble kicking up the adaptive system of our immune set. And in our Lyme population, quite honestly, we do have problems with our adaptive system. That's why the IgG is low. That's why the T counts are low. So, you are at some risk. But, take your, go ahead and isolate, wear your mask. Take your little cocktail. Take your quercetin, vitamin B, vitamin C, vitamin D. Be sure you're taking those things. And by the way, I'll talk about this in London, but nattokinase is a really cool finding that we have that I'll be writing about. It's a fibrinolytic, very mild enzyme derived from soybeans and B. subtilis, and it inhibits PAI-1, which is a procoagulant, which is elevated in COVID. And it may be elevated in Lyme. And so we're going to start testing for that in our Lyme borreliosis patients who may be at risk for more endovascular disease. It's mild enough as a biofilm degradation agent that it's safe to use in my view. So it's mild, doesn't break down biofilm and create chaos. But anyway, take your package, be good about it, detox, and that's the best you can do for your immune system.
And just as a clarification, Dr. Jemsek is not going to be in London. He was supposed to be in London, but because of the pandemic, he's going to be doing a lecture that will be shown through Zoom or virtually. He just won't be there in person, just as a clarification. This is kind of a piggyback question to the very thorough answer you just gave us, Dr. Jemsek. There was a question about whether a patient getting testing for the antibodies for COVID, what could that mean in regards to their immune system? Is there a chance that it could be reactivated in the same way as we know happens with other viruses when patients are immunocompromised?
That's an excellent question, and we don't know, and I think it could happen easily. Excellent question. It depends on the, it always depends on the intrinsic virulence of the infecting organism and the capability of the immune system. So it's always that. It's always the yin and the yang. So don't know, but I think that's an excellent question. I think it could easily happen. And really, folks, it's all about getting that immune system in the best shape possible. That means getting sleep, eating correctly, minimizing stress, finding ways to do that. And easier said than done, I get it, but that's what we have to do. We all have to do that. The human biome just can't handle these waves of infections, I don't think. We're not, this is a new organism for us, and we're just not prepared. And people talk about herd immunity. That sounds great, but we're not all from the same herd.
A good question that just came up on the live too. Someone was asking that they had heard that if you have Lyme disease, you don't necessarily catch viruses like COVID. Is that true? And we don't think that that's true. We do think that Lyme patients can get COVID. We do have a number of our patients who have tested positive. We do think because of their immunocompromised state and their response to illnesses or viruses, they may present with different symptoms, which is happening with a lot of people. But that was a good question that came in from the live. Another question is, what are the most likely reasons that a patient can't quite make it into remission, especially if they've had years of successful treatment and keep getting to maintenance, but then can't hold on to the improvements that they've made? And this is a great question and something that's very frustrating for patients, understandably. We think that there are a myriad of things that could cause this. On our website, we have a list of about 25 co-founders or confounders that can cause relapse or cause patients to have issues going into remission. One of the big problems that we find is Babesia, and Dr. Jemsek touched on this a little bit earlier, but we think that because the Lyme bacteria and co-infections can hide in different parts of the body, many times that stubborn co-infection of Babesia will be hidden in small pockets and will resurface, many times causing a relapse of symptomology. A lot of this is also to do with continued leaky gut issues or gut health that can cause patients to have a resurgence of symptoms. All right, let's see here. This next question, Dr. Jemsek, you touched on a little bit, but we'll make sure that we kind of hammer this home. What would be your top tips for lowering inflammation and strengthening the immune system?
Essential life functions which are destroyed or disturbed, I should say, in this unique infection process, where we've never had an illness that was so efficient in terms of invading and maliciously marauding through the brain and peripheral nervous system. We've never had anything like this. This is like syphilis on steroids, and that's not even accurate. It's like, syphilis on nuclear with nuclear power. The spirochete is easy to kill in the test tube, but it's hard to catch in the body. And so the question was about how to reduce inflammation. So I've used the acronym POEMS for years, just to say, okay, we have to go through a stabilizing process. I think most people know my approach, which is take 3 to 6 weeks to stabilize or longer. For example, you might need your gallbladder out before we start, and you do that by identifying the outliers on the lab work, a careful examination, a careful history, identifying the risk factors, prioritizing what they need to do. But POEMS has to do with P standing for pain, O standing for other, which can be comorbidities, but more importantly, it's do they have support? They have somebody that's willing to stick with them, because in extreme cases, people lose the will to live because they can't communicate. I mean, everybody knows it gets that bad. E is for endocrine issues, which are extremely important, particularly the adrenal axis. If you don't have the adrenal axis working, you die. M is for mood. You have to be on the playing field, folks. So I'm happy to work with psychiatrists, but we do a lot of psychotropics. I think we're pretty good at it. If you do have a psychiatrist, we're more than happy to work with them. But we have to get you stabilized because your brain's on fire. And a lot of the drugs don't work all that well. We have ways of calming you down, both through therapeutics and through behavioral change. And the last is sleep. So, and then we use a modicum of what I call tier 1 antioxidants, which I've already mentioned, which are omega-3, curcumin, resveratrol in most women, but be careful, and quercetin and vitamin C. So you take a modicum of supplements because your antioxidants are consumed. They're gone. They're burned out because you're on fire. You got chronic inflammation 24/7. So you need those supplements. And we look at gut health and we look at everything. But there's no easy or short answer for that. But POEMS is something we go by. We have check boxes on every single patient, trust me.
Another live question asking about MRI findings. Wondering whether an MRI that shows no apparent damage to the vestibular nerve, but having vestibular and auditory issues, wondering whether treatment can help heal hearing loss, or can that be reversed? I would say, and chime in if you agree or disagree, Dr. Jemsek, many times we will see normal MRIs, but cognitive dysfunction, vestibular issues, so on and so forth, and we think that that's quite simply because the infection's been in the brain, but maybe not long enough to cause a scar. So a normal MRI is not necessarily indicative of a patient that doesn't have any issues in those areas. We do think that treatment is your best shot at reversing those symptoms, in the sense that if we can remove the bacteria that is causing that neuroinflammation and infection, the nerve will then have a chance to heal. And when it has a chance to heal, it can then show improvements in regards to hearing. The other question linked with that a patient had written in about was wondering about white matter changes that were seen on brain MRIs, so actual abnormalities. Will they resolve with treatment? And this is something Dr. Jemsek and I get asked a lot, that patients are concerned about. They'll say, will these lesions continue to show up on my brain MRIs? And the answer is probably yes. Sometimes they will go away or fade, but many times they will stay present. The interesting thing about the brain is that it is constantly able to create new pathways, particularly once it's not under the burden and stress of an infection. It can start to heal. So even if you still see those lesions or scars, you will still see improvements in symptoms in regards to cognition and the other symptoms mentioned. One other question I wanted to get to, because I know we're running short on time, a question that many of you have brought up is whether Jemsek Specialty Clinic is utilizing Disulfiram, and what our thoughts on that are. Dr. Jemsek?
No. I'm not on the bandwagon, folks. I've treated too many people successfully, And I know too much about the complexity of this illness to think that one drug will handle multiple pathogens, heal the gut, boost the immune system, and so forth. But here's the deal. I understand. I'm very sympathetic to the fact that 90+% plus can't get to a decent physician or somebody that really knows what they're doing. A lot of people these days say they can treat this disease and they can't. And so this is going on quite a bit as the medical boards have relaxed. So people are popping up everywhere, and it's not working out in the most cases. So we've treated over 13,000 patients. Our programs have evolved slowly over time, carefully. And I may look at Disulfiram as an adjunct later on, or as a booster of some kind later on, but I need to see more data. I guess I want to get back to the original point, or one of the points is that I'm sympathetic to people who say, okay, I don't have anything else to try, I want to try this. And I can't afford to go here, there, or whatever. I don't have access to care, but let me just try this. And they do. I get that. People are desperate. But come on, folks. A single drug for this infection? No way.
So I think we have time for one more question. This one, patients were asking, how can Lyme and co-infections cause psychiatric issues like depression, and does it get better with treatment? As we know in the Lyme community, patients can present with lots of different symptoms. It's not always joint pain, it's not always fatigue. Sometimes it's purely psychiatric. And many times those patients will come to us or eventually find us because they won't respond to normal antipsychotic medication or antidepressants. We think that this is because the brain, and particularly the limbic system or limbic part of the brain, gets infiltrated with infection and also inflammation. And so it affects your ability to interact with your surroundings. Now, whether that be in light of light and sound sensitivity, or anger, irritability, things like that. So it's very common presentation. We do think that this gets better with treatment. Many times patients will need to be stabilized before they're treated because the limbic part of your brain is fragile. So we use medications to neuroprotect that area of the brain before we treat, so it doesn't cause permanent damage and is unable to be reversed. And then one final thing a few of you had asked is whether we're going to be continuing the Facebook Live events. We're going to try to do them, I think, monthly going forward. You guys have sent phenomenal questions in, and I think that it would be worthwhile to continue this platform so that we can get as many of them answered as possible. So we look forward to seeing you guys next time.
Yeah, I'm really enjoying this, and questions are fantastic. Doing the best we can. What you have to understand is we're learning too. We're learning every day, every week, and there's so much to learn about this illness. And it's so frustrating to, quite honestly, see COVID come in and dominate probably for months, a disease that is in its own way equally or more critical to the health of the population than COVID. And I say that, and people say that's heresy. Look, I was an HIV doctor for 20-some years, and I saw the sickest people on the planet, and my Lyme population is worse. And there's a lot of reasons for that. So we love you, and we'll see you next month. Thank you for the questions. And we've got Yusuf on the Facebook and Instagram doing a wonderful job, because that's something I could not do. So see you next time.